and today's webinar is about hot topics in diffuse large B-cell lymphoma. I'll take a moment to introduce our speaker. Dr. Ariela Noy is a board-certified medical oncologist and hematologist who cares for people with Hodgkin and non-Hodgkin lymphoma, as well as other cancers of the lymphoid system. She has been practicing at MSK since 1997. Dr. Noy is part of a tight-knit team of experts who provide the best care for their patients. And I'll turn the time over to her.
Great, fantastic. Thank you very, very much for asking me to give this lecture. I'm going to share my screen. Hope it works. Great. Can someone confirm?
I can see it.
Okay, great. Let me just remember how to advance the slides. Okay. So as mentioned, I did my fellowship at MSK, and I wanted to work here since I was, I think, in the 7th grade. So here we are. I do a lot of different things, but one of the main things that we all do as lymphoma specialists is work in diffuse large B-cell lymphoma because it's the most common. I want to thank immediately Dr. Jennifer Liu. So I cannibalized some of her slides and added a few of my own. So I'm indebted to her for saving me a couple of hours work, which I very much appreciate. She's a junior attending here at MSK. What I'm going to do is give you some background on what is diffuse large B-cell lymphoma, what are the common approaches to it, and then what are the controversial topics. All right, so diffuse large B-cell lymphoma, what we do is we work with pathologists. So all lymphomas are cancers of the immune system. They're 90% are B as in boy. Those are the cells that make antibodies. 30% of all the lymphomas are not of non-Hodgkin lymphomas are diffuse large B cell. So that's an estimated, she's got here 150,000. I think that's a lot, actually. I think overall non-Hodgkin lymphoma is about 75 to 100. The median age is 65, but it's very broad, and you have peaks of older patients and you have also peaks of younger patients. And we'll touch upon some of the geriatric issues, which are exceedingly of interest as the population ages, sometimes as your doctor ages. The majority of patients present with stage 3 or 4 disease. And I think that's important to emphasize because it's not a solid tumor. And when we talk to patients, they always come in and they say, oh, what is my stage? And then my voice drops and I say, well, it's advanced stage. And they say, well, can you give me a number? And I say, well, you have stage 4 disease, but, and I can't even get the sentence out before some people are, understandably barely conscious at that point. And the reason is when we treat solid tumors, we know, breast cancer, lung, prostate, right? Anything that is metastatic in stage 4, with very few exceptions, is incurable. And even if patients live for, let's say, 7 or more years with a adenocarcinoma, they're getting chemotherapy and they're miserable intermittently. And that's not what the situation is, because stage 3 and 4 disease for diffuse large B-cell lymphoma is the norm and is still curable. It can arise from an underlying indolent lymphoma, such as follicular or marginal zone or CLL. That's called a transformation event. It is associated, not exclusively, but higher risk in patients who have immune deficiency, and that could be a solid tumor organ transplant, autoimmune disease such as lupus, rheumatoid arthritis, or Sjogren's, and HIV. It is driven in some cases by viral pathogens such as Epstein-Barr virus, HIV, hepatitis B, Hep C, and HHV8, which is another type of herpes virus. But we should keep in mind that the vast majority of people who have those viruses do not get lymphoma. So it is a risk factor, but it is not a etiology in and of itself. and especially Epstein-Barr, because 90 to 95% of Americans have Epstein-Barr virus, which is commonly known as mononucleosis, before the age of 25. And obviously not everybody has lymphoma. And then lastly, there's a very extensive biologic heterogeneity, which we'll discuss. All right, so when we see someone, what do? We try to decide where the disease is, and we also do labs and things like that. But graphically, you can see here that stage 1 means localized in one area. Stage 2 is 2 distinct areas, but above or below the diaphragm. Stage 3 is this and this below, above the diaphragm. And stage 4 means that an extranodal area is involved. Could be the lung, the liver, the bone. Now, why would we even do this? Well, first of all, it has prognostic implications. So as you go down this pathway, these are more virulent and harder to cure. Also, they have treatment implications, which I will show you, because some patients who have early stage disease can have more limited therapy. And lastly, part of it is historical. So back in the 1970s, when only radiation therapy was available, the entire staging system became constructed based on the idea of, oh, you can radiate stage 1 easily, stage 2 easily, stage 3 not, and stage 4 impossible. So really, there's a historicity that is involved in this. All right, so one of the things that has been around now for more than 25 years is a simple clinical index, not meant to be memorized, just to give you an idea of, the least problematic, best outcomes to the worst. And what you can see here, we'll just look at the first one as an example, because they really are all quite similar. Is here, people who have the lowest risk had a 90% outcome at 5 years. And the chances that they would relapse is the difference between these two numbers, so only 7%. In the modern age, adding rituximab, because this paper was published in the early 90s, that goes up from 87%, from 81 to 87, 88 to 93, and then there's a refinement here, which frankly, I never use this refinement. So, but the difference is really it's splitting hairs, because the numbers are very, very similar from one staging system to the other. And we can use this, and people say, well, what is my chance of my beating this, right? And so we don't always give people an exact number, because it's not always helpful in clinic. It can sound kind of harsh, but we might say, well, nearly everyone, who has this situation is cured. You're in the top tier. Or we can say, well, unfortunately, you're in the lower tier. It's better than half. We may be a little vague, and then see if people actually want those numbers, because not everybody really wants to know an exact number. And you have to be sensitive to that. Okay. The important thing here is that there are no biologic characteristics that are specific to a pathologist looking at something and saying, oh, well, this looks a little bit more aggressive, or that looks less aggressive, or we're taking into account genetic testing or cytogenetics. So I can't believe it's 20 years already since this was published, 22. So this is called gene expression profiling. It is not commercially available even now. So gene expression profiling was done to say, what are the genes that are actually in these lymphomas, and then using machine learning to try to group them. So the hypothesis here being that cells that look more like something called the germinal center would be more aggressive, less aggressive. That's the orange line, that's the outcome with standard therapy. And then the blue and purple would be more aggressive, and that is exactly what turned out. There are alternatives to this. There was a more complex system that is not really used. And the reason is that in the second paper by Hans here, they were able to say, well, gene expression profiling is not really available, sadly, 2 decades later. But we can approximate this using protein tests on slides. And we just call those germinal center and activated B cell types um, in the gene expression profiling, and we call it germinal center and non-germinal center when we do it in the protein tests. So we can use that. And that can also give us information about prognosis, and now can also potentially influence treatment. Right. And that shows you what the protein test was done um, to recapitulate the other tests that were done by gene expression profiling. Now, we're not going to memorize this. I don't have it memorized. I know very few people who do. But more recently, this much more complex system was created, and it's a refinement. We do not have access to this clinically. It is done on gene expression profiling again. And all of these clusters were done as genetic hallmarks. You can see it's very complicated. But what it does is it tells us that we should be targeting these patients for new therapies. And if we don't do that, we're making a mistake. We should not be treating patients in these groups necessarily with the same type of novel therapies if we can avoid it, because we're putting people at risk. All right, so overall, just to explain what we do, we say, okay, somebody has diffuse large B-cell lymphoma. What's their stage? Is it limited? Is it bulky? Or is it advanced stage? Do they have any of these other things that we need to think about? These are chromosome studies that indicate higher risk. Do they have clinical risk? Do they have a risk of developing lymphoma in their brain or in their spinal fluid? And then we divide that up clinically and we say, well, you can have this treatment or you can have this new treatment. And I'll go through that a little bit. All right, so this is the basics. This has been around for something like 40 years. It's an antibody that was added in 2004 to the armamentarium of chemotherapy that was used for 20 years before that. It was the first randomized trial to demonstrate an improvement in the outcomes. It's given every 21 days. It's pretty simple to give outpatient, except for certain exceptions, usually for cycle 1. And I will skip the prophylaxis because it's too detailed for this audience and not really necessary to delve into. So what is new relatively is that about 5 years ago, this randomized trial of about 550 patients conducted in 4 different countries demonstrated that if you had limited disease, you could have a short course. It's important to actually look at who was eligible for the study and how they designed it. So patients were all less than 60. They had a normal blood test called lactate dehydrogenase, and they had relatively small volume of tumor. And they were randomized to a full course of chemotherapy or 4 cycles of chemotherapy with a couple of doses of immune therapy that actually nobody bothers to give because it doesn't make any sense. And they were reassessed after 3 cycles. If they had a normal PET scan at that time, they completed their treatment with 1 more cycle. If they had a positive PET scan, they went on to give a total of 6 cycles of chemotherapy. It's basically flipping you to the other arm, or radiation. That was dealer's choice. So you can see here the outcomes are excellent. Progression-free survival means that the patients do not relapse. And we know that after 3 years, it's very unusual for someone to have a relapse. And the results are so good that the NCCN guidelines no longer require additional radiation monitoring, radiographic PET scan or CT after that end of treatment scan. Okay, what about advanced stage? So we gave our CHOP for 20 years, and this was a randomized trial of a new drug called polatuzumab. And the patients were randomized. You can see this just came out within the last 2 years. to this new drug, polatuzumab, dropping a drug, vincristine. Now, why would you do that? So I will show you in the next slide. How does this work? Polatuzumab is an antibody drug conjugate. That means you have this big molecule and it sticks to a protein on the cell surface called CD79A, 79B, which is part of the B cell signature. So all the B cells in the body will have that. And when it's engulfed, it gets metabolized internally. And these little orange star shaped things, they are the chemotherapy. So not the big blue thing, but the orange stars. And the idea here is that the orange stars are chemo, but now you have a much higher level inside the cell than you would ever be able to give someone if you gave it intravenously. And this concept had already been shown in Hodgkin lymphoma, targeting a different protein, but it was like the miracle drug of the year, I think, in 2006, named by ASCO as the biggest, breakthrough for Hodgkin lymphoma. So there was a precedent for this, and it made a lot of sense to try this with chemotherapy. I will say that just prior to this, another randomized trial suggested that a different approach was also helpful. Um, but it was a complicated study and it did not get an FDA approval. So we had not had a change in almost 20 years when this study came out. All right. Again, always important to know who was on the trial. So most patients did have advanced stage disease. Oh, I didn't realize she has, sorry, I don't like to have animation. Um, so this looks like a very small difference. That is true, right? However, and this is not the overall survival data, we don't have enough follow-up yet to know. The median follow-up here is only about 18 months, and we really need more follow-up to know. But even so, if you don't relapse and you don't have to go on to another therapy, that is a big deal, right? Even if it turns out that the two arms end up with the exact same survival because the patients relapsing here go on to a new treatment, you are saving a lot of people grief and toxicity. And I'll show you what some of those additional therapies are. Nobody would want to get that therapy if they could avoid it. So one of the issues is, well, this difference isn't that big. Is it more toxic? Does it make sense? And we are talking about a much higher expense because the drug that we took out, vincristine, probably costs like $100 a dose at most. And adding polatuzumab is several $1,000s a dose because it's brand new and it's on patent. Okay. So here we have the toxicity. It was surprising. The polatuzumab vedotin was designed not to have that drug in your bloodstream. So it should have had lower neuropathy because you're dropping the vincristine, which causes neuropathy, and it was the same. So that is a little bit of a disappointment, but overall, the toxicity profile was basically identical, except for diarrhea. And I have to say, I have not had a good experience sometimes getting patients through with this diarrhea, but it may be just, luck of the drawer that I had the first patient I gave polatuzumab to quite miserable with diarrhea. Okay, so you can see that. And then there is a slightly higher risk of febrile neutropenia, but it's not significant and it may be the same. All right. Then there was a lot of controversy about who really benefits. So it turns out that the highest benefit, the way the study was designed, was in people who had the greatest risk in terms of their clinical risk profile. And subsequent data has demonstrated that it's likely, although not definitive, that patients who have this ABC subtype, also known as non-germinal center, as we discussed earlier, probably benefit the most. There was a subsequent letter to the New England Journal that demonstrates that a subsignature called dark zone signature, which again is not commercially available, may also benefit. So we have some controversy, I would say, nationally and internationally about who should get polatuzumab. Okay. We're going to move on for a second to high-grade tumors. I guess I didn't catch this when I was editing. I would take out these B-cell 6 arrangements. This is no longer considered a high-risk factor. So patients who have lymphoma with MYC and BCL2 have a high-grade phenotype. They are predominantly in the lower risk group of germinal center. So it's a little bit strange, but if you have germinal center, it's a good thing. We saw that before. But if you have germinal center with BCL2 and MYC, that is bad because MYC is a driver. It turns on everything in the cell to be highly proliferative. BCL2 makes the cells die. And if you have the BCL2 blunted so that you can't kill the cells and you have too many cells, it's like you're filling a bucket with cancer cells faster than you can possibly get rid of them. It is a bad scene. So it's a small number of patients, relative, it's about 5% overall. They have very bad outcomes with R-CHOP, and generally we give this dose-adjusted rituximab epoch. Now, this is not based on randomized data. This is based on multi-institutional data demonstrating that this is probably better. In fact, a randomized trial of R-CHOP versus dose-adjusted R-epoch showed identical outcomes when all patients were considered, but that did not preferentially look at these patients with high grade. So we generally will not give R-CHOP. It's a much more difficult treatment, dose-adjusted R-epoch. It's 5 days. You need a special line. It's more immunosuppressive, much more likely to get a blood transfusion, 22% risk of hospitalization due to infection. Now, within this group I mentioned earlier, there's this dark zone signature, and some of these patients, again, will have double hit or BCL2. Again, we can't clinically identify them, but it seems like they do the worst if you actually did gene expression profiling, but we don't have that available. High rates of central nervous system relapse. I will talk about prophylaxis momentarily. This is a very fraught area in lymphoma. Okay, I'm just going to mention this talk is not about Burkitt lymphoma, but Burkitt lymphoma is a little bit different. And I'm leaving it here in the talk so that we recognize it. You have to rule that out at diagnosis because all of those patients need a very intensive approach. Okay, so going to another subtype, this is called primary mediastinal. So these are predominantly women. There's a complicated differential diagnosis that gets adjudicated by the pathologists. And we tend to give dose-adjusted R-epoch based on data from the National Cancer Institute and from Stanford. It was, again, a non-randomized trial. The outcomes are excellent. The reason why we would do that over rituximab CHOP is that rituximab CHOP was given in these patients with radiation. And you can imagine you are taking a young person, you are radiating their aortic valve, their coronaries, and their breasts. So this is a problem. Now, the other interesting thing is, so current studies are all looking at non-radiation approaches. What is super interesting is that there is a protein called PD-1, and similar to Hodgkin lymphoma, what PD-1 does, there's an interaction between the B cell and the T cell, and the B cell cancer cell will block the ability of the T cell immune cell to kill it by expressing these red and blue proteins called PDL1 and PDL2. So we now have a whole new set of drugs, which were developed initially in melanoma by seminal work done here by Dr. Houghton and then Dr. Walchuk, looking at drugs that block the block and allow the T cells to kill the cancer cell. So there are ongoing studies looking at whether or not adding these immune checkpoint inhibitors to these situation will improve the outcome, and it's very promising. Okay, some patients will develop cancers because they are immunosuppressed and they may have gotten an autologous stem cell transplant or an organ transplant. Early cancers are often associated with EBV. The cells will morph from an early type of what's called early lesion to polymorphic to monomorphic, and some will be classical Hodgkin. How you treat that depends on what the organ is, because if you decrease immunosuppression on a heart transplant, there's nowhere to go. Patient will die. So, but can't do that. You have more room on a kidney transplant, probably don't have much room on a liver transplant. There is data to suggest that you can give rituximab alone to patients that are not acutely ill and see if you can get the disease to go away. But many patients will end up with chemoimmunotherapy. We have interesting things for patients who have refractory disease, including something called cytotoxic T cells against the Epstein-Barr virus, if they are the ones that have the EBV-driven tumors. And the rest of these, I would say, are experimental at this time. What about the elderly or frail? Well, it's important to think about that because, as I mentioned earlier, our population is aging. I don't know what people's average age is on this audience, but certainly when I was growing up, I thought people over 65 were old and people over 80 were ancient. And now we have many, many, many patients coming in who have survived into their 80s because they are no longer getting heart attacks. They get stents, they have better lipid control with all the new drugs. They have better, lower risk for strokes. So they need a geriatric assessment. And again, not randomized data, unfortunately, but work spearheaded in France demonstrated that you could reduce the all cause mortality and treatment related mortality if you cut the doses of chemotherapy. Now, that's counterintuitive, but it actually makes a lot of sense because people who are older, they may have a completely normal profile when you look at their liver function tests or their kidney function. But if you actually calculate out what their true kidney function is, since it's inversely proportional to age, just the fact that you reached age 80 means that you have lost a lot of your normal kidney function. So again, I'm going to say that again. A normal blood test, but the influence of age means that they've lost their normal kidney function. And that's the same true of the liver. We just don't have a way of calculating it. So it's been shown that the pharmacokinetics, meaning the metabolism of the drugs, is so different that if you give full dose chemotherapy, you're actually giving a biologic dose that is too high. And so studies currently are building on this idea of our mini chop. Sometimes you have to look at the patient's other organ issues. So people who have a depressed ejection fraction should not get the H drug, hydroxydonorubicin. We substitute and give gemcitabine, or we drop it, or we give etoposide. So we have to be very careful. Another thing that we learned years ago is that the first cycle of chemotherapy in a frail patient can be associated with as high as a 20% mortality in that first 3 weeks. So giving something called prephase with either just the antibody, monoclonal antibody rituximab, or a low dose of vincristine will very often get somebody's tumor volume down, improve their performance status if they're meaning how well they're walking across the room, right? Whether or not they can make themselves a sandwich. Can they get to the bathroom by themselves? So that, if it is a reflection of their tumor burden, then giving that prephase makes a lot of sense and it improves their get up and go. And then you can come back in with your chemotherapy for the next cycle much more safely. A current randomized trial is national study is looking at our mini chop plus or minus a drug that makes the cells potentially more susceptible to chemotherapy. All right, we're going to touch on this. This is a can of worms. We can identify who the people are who will have cancer come back in their spinal fluid or their brain. The problem is none of us can figure out what the heck we're supposed to do with it. And it's not for lack of trying. It has to do with the fact that it's hard to study something that only happens rarely. So if we look, we can identify those patients and say, well, your risk is low, it's 2%. Your risk is high. And in some patients, we can even say it's as high as 15%. But it's very, very hard to study those patients prospectively. The median overall survival, if you have a relapse in the brain, is less than 6 months. So what do? Well, for a bazillion years, we gave everybody spinal treatment, direct chemotherapy into the spinal canal. It may work. We're not 100% sure. We know it works when somebody has cancer in the spinal fluid, but that's not the same thing as saying, does it prevent? Or we can give high dose chemotherapy at the end that does cross into the blood brain barrier. But again, we don't know if that works. And if you're giving it at the end, you've now had 18 weeks for the cancer cells, if they're already there, for them to grow. Also, this requires hospitalization and it's kidney toxic. And since we said that older people already have depressed kidney function, you can give somebody permanent kidney troubles. So this is not a an agreed upon right now. And I think we've moved back from saying, okay, everyone who has this CNS score that is high should get treatment, to having a discussion with the patient. So what's new at MSK is we are trying to do a new test, which will test for cancer cells by DNA, nucleic acids, in the spinal fluid, and see if we can identify those patients earlier who really might benefit from treatment. I'm going to skip this one. All right. And you can see that all of these things are really dependent on what you're giving for chemotherapy. So if you are giving more intensive chemotherapy, the belief is that you have a lower risk for central nervous system relapse. And that's probably true, because if you can't control the underlying disease, you probably can't control the CNS relapse either. So where we are right now is this discussion. You say, well, you're high risk. Maybe what we'll do is we'll check your spinal fluid. We'll give you 1 dose of the spinal fluid chemo. If it's negative, what should we do? Should we continue? So there is an attempt to randomize patients at that point to intrathecal or not, or high dose therapy or not. I don't know if they're going to get there. It's a very hard study to do. Yeah. So far, no impact. So in long-term survivorship, what do? Well, if you have low risk disease, we actually recommend just clinical follow-up. If you have anything that's intermediate or high risk, we recommend imaging no more than 6 months. And in between, we monitor clinically. It's important for people to call if they have a complaint, so we can say, oh, that's nothing, don't worry, or gee, let's have you come in and just take a look, see. Patients who have a complete remission that's sustained at 2 years are unlikely to relapse, but between years 3 and 5, it can happen. In long term, there are issues with infectious complications, secondary cancers, and cardiovascular events. I wish I could say everyone can see a special survivorship practitioner, but it's not as easy as you would think, because we graduate many people and we don't have the bandwidth. All right, what do we do if somebody's treatment does not work? So this was a paper published 7 years ago. These are the patients that have a complete response. It's not likely that, sorry, I should say this differently. Patients who had primary refractory disease within 12 months don't do well. That's how I should phrase this. And it didn't really matter what was being done. You can get a little bit of bang for your buck with, you can see here, an autologous stem cell transplant does cure some people, but we're not doing very well. It's about 35% of patients, right? So we knew at this point that we really needed to do something better than autologous stem cell transplant, although we knew that we were curing some people. And an autologous stem cell transplant, for those who don't know, is when you take out the stem cells from the bloodstream, freeze them, give high doses of chemotherapy, and then rescue the time that it takes for the normal cells to come back, and makes it only a few weeks compared to a few months. And it capitalizes on chemotherapy sensitivity. But overall, only 30% of patients that had a relapse were benefiting. And yes, you can see here that somebody who was previously in a complete remission would do better than somebody who had primary refractory disease. All right, so what can we do? So what we know is that we know a lot more about the biology now, and all of these are different proteins. So we have clinical trials trying to capitalize. For example, we have an inhibitor that works here. We have drugs that work here. We have drugs that work here. This is an FDA approved drug. It doesn't work very well. So what are we doing? What we are doing, if a patient, this should be updated, CAR T cell therapy is approved for patients that have who need second line therapy and have relapsed within 12 months, or have relapses beyond that 12 months and did not do well with chemotherapy and a transplant approach, or anyone in third line. And I'll show you some of the data for bispecifics. And we now have all of these other approved drugs as well. This is the same polatuzumab that we saw before, which is the antibody drug conjugate mixed with chemo. This is another antibody drug conjugate targeting a slightly different protein with a different payload. This is an antibody to the B cell receptor with a drug that's supposed to kick in the immune system by working down here. So what is a CAR T cell? Well, we knew that if you took patients that had lymphoma and you gave them somebody else's immune system, you could cure some patients. Doesn't work super well, unfortunately, for diffuse large B-cell lymphoma. We mentioned before that if you had a virus that was part of the machinery that was making the cancer, then you could cure some people by giving them a virus-specific T cell. Well, that's a minority of patients, and it doesn't work that well. Then there was the idea, what happens if you took the tumors, ground them up, mixed them with the person's immune system, and grew them up in a lab and stuck them back in the patient? That didn't work. So we got to these. Well, you would take the T cells, genetically modify them, put them back in, and that seems to work. So this is where we are now. These are called chimeric antigen receptor modified T cells. The T cells are removed. We genetically modify them in the lab. This is done commercially primarily, and we put them back in the patient. And I would like to thank Dr. Palumba for this set of slides. All right, so here's the way it works. Here's your CAR T cell. You've put in this engineered is the word I was looking for, engineered antibody. It sticks to the cancer cell. And this is a cell that kills its target, and it works. This is crazy, but it works. It's Frankensteinian. It works. How do we know? Well, here are some pivotal trials. So all of these patients, They had already gotten chemotherapy that did not help them twice. And they went on to this trial with absolutely no other cure other than a small fraction that could have gone to allogeneic transplant. Right now, we think that the 5-year estimated cure rate is about 40%. And we know from that Scholar 1 that it would be all the way down here, 10% or 20% at most. So this is, even though it was not randomized data, 40%, there's no other way to interpret this really. So this got approval. Then Juliet was another trial of a different company. So this is Axicell and this is Tisacell. Pretty comparable results, not compared directly. Well, what was the problem with those is that Axicell is kind of toxic. So here is another company, and this data was on a different product. So the Axicell drug and the Tisacell drug were developed at UPenn and NIH. This one was developed at MSK and similar. So patients who have a complete remission to this drug do very well. The green is patients who have, green, I don't remember right now. Oh, green is the total. Okay, so green is the total. Orange is the people who have a complete remission, and it happens very fast. It happens within 30 days of this one-time drug that you're giving. These are the patients that have a little bit of a response, and then the non-responders. So these two don't benefit, and we don't know how to parse them out in advance. We do know that if you have a heavy tumor burden going into it, it's not as favorable. This drug is far less toxic. The two big toxicities are called cytokine release syndrome and neurotoxicity. And we now have much better ways to manage and control the first one. We have no clue how to prevent the second one, except for possible protein drug, which is approved, but we don't really even have randomized data for that either. All right. And then lastly, what is a bispecific antibody? So a bispecific antibody is a drug that touches the B cell, which is the cancer cell, touches the T cell. So it's also called a T cell, B cell engager. And it literally just brings the two partners close together so that when they can, quote, see each other. Okay, it is truly miraculous. And what this shows you is if you take people who have DLBCL in third line or beyond, every single patient here had a benefit from the drug compared to these patients who don't. And all the ones in blue have a complete response. It again happens very, very quickly. And if you have a complete response, the chances are this is short follow-up, but at a year, you can see here it's seemingly not dropping off. We're not sure yet. So we will have more information as we go forward. It's not clear how this compares to the CAR T cell approach, but we can take this off a shelf. You don't have to send the patient to a special room, have their T cells removed, send them to a company, wait 3 weeks, get them back, give them chemotherapy in between. None of that. So ideally, anyone living anywhere can get this, and they don't have to go to a specialized center. It's not entirely true because there is toxicity and you have to know how to manage it. And I don't think a community oncologist is going to be very excited about that, at least not at this time. But it is much more accessible. All right, so just to compare, this is the present and the future. This is an antibody that was developed 20 years ago. It does work. It works in acute lymphoblastic leukemia lymphoma. It works in pediatric acute lymphoblastic leukemia lymphoma. It's very unwieldy. It is super toxic, and it's given by continuous infusion. So you can imagine that is not fun. This, these are all examples of that bispecific that we just talked about. This shows you that people are thinking about things like, wait, can't I just give more of one of these drugs and link them together? Maybe that will work. Maybe it'll work if I mix my drugs so that some of the targets are against one protein and some are against another protein. Maybe that will work better. So, this is all what is going on in research. And then this is super interesting because here you have the standard CAR T that we talked about, where the cells are removed, transduced by a virus to get your antigen receptor and put back into the patient. Well, how about this for fantasy? How about we don't even take the T cells out and we just give them an injection in the clinic that will find its way into the T cells, either using nanoparticle delivery or a virus. So, this is what is being worked on now as we speak, and it'll be very interesting to see what happens going into the future. So, my conclusions are this is a very common type of lymphoma worldwide. It's highly aggressive but curable. We know a lot about the biologic diversity, but we don't really know how to target our therapies very well. So these are all ongoing. Um, Treatment is dependent on stage, the IPI score, and pathologic features. I wish I could say it was more refined than that right now, but it's not. We talked about antibody drug conjugate polatuzumab as an option for patients who have standard DLBCL, and we talked about how some patients have high grade features. Um, I touched on primary mediastinal and Burkitt and discussed how we use non-radiation approaches by incorporating a different infusion therapy schedule, but not based on randomized data, and how there is randomized data that will be generated because there's an ongoing national trial using immune checkpoint inhibitors. We discussed that about 20 to 25% of patients will be unfit. I have to say that is a number I don't find, but we are a tertiary care center, and I think somebody doesn't always send their sickest of sick in for a consult, and we can dose modify. And finally, the role of central nervous system prophylaxis is rife for exploration. It is a very, very fraught topic. And with that, I'd like to conclude.
Thank you so much, Dr. Noy. That was a wonderful presentation. I'm going to
Thank
re-share
you.
my screen here. Okay, it's now time for the discussion part of today's webinar. If you have any questions about DLBCL or anything Dr. Noy spoke about today, now is your chance to ask questions. This time is set aside specifically for community members to have a chance to talk to our incredible presenter. So feel free to ask your questions if you have any. As a reminder, you can ask a question or make a comment in the chat box or raise your hand if you would like to ask verbally. If raising your hand, once you're called upon, you can unmute yourself. Let's see. While I'm waiting for any chats, I did have a question. You mentioned stem cell transplants. Could you tell me who would be eligible for those?
Okay, this evolved. I have to answer this question. Sorry, we have a fraud. Give me 1 second.
Oh, there it goes. You
Okay.
can answer that one first.
Yeah. So it's evolved. So we used to say anybody who had lymphoma at the end of therapy would get chemotherapy and a transplant if the second line chemotherapy worked. Similarly, anybody who had chemotherapy a long time ago, like a year ago or 2 years ago or 4 years ago, and they had a relapse, they would get chemotherapy. If that worked, they would get a transplant. A randomized trial. So the first CAR T cell trials were not randomized. I showed you those. What I did not show you, just because of time, is that the iteration of that was done as a randomized trial as follows. So patients who had a relapse less than 12 months before are considered higher risk, and they were randomized to the standard of care at the time, which was chemotherapy and a stem cell transplant, or straight to CAR T. And what that trial showed is unequivocally the straight to CAR T was better. It was better in terms of disease control, and it was better for overall survival, even though patients who got randomized to the standard of care arm were allowed to cross over later on and get the CAR T because it was already approved for that setting. Um, so we no longer offer stem cell transplant to patients who have primary refractory or a relapse within 12 months. They go straight to transplant. What is not clear is really if a CAR T would be better for the patients who relapse after 12 months. And I don't know that that trial is going to happen. Ideally, what we do know is that the better we do in first line, the fewer patients will have a relapse or primary refractory disease, right?
Mm,
And then they will not need all of this second line stuff. Does
okay.
that make sense?
Yeah. Thank you. We have a question from Cindy that says, any suggestions for dealing with R-CHOP side effects, specifically issues with nausea and headaches?
Ah, okay. Thank you for that question. So nausea is something that has been worked on for like 30 years. And we have a plethora of drugs that block a protein called serotonin, and that reduces nausea even before it starts. We still send people home with anti-nausea medicine, but it's not used as much as you would think. And then the second question was headaches. I would say headaches are not common. They are a side effect of the anti-nausea drug. So we try to tell people, don't use the anti-nausea drug unless you need it. Don't take it around the clock prophylactically. And the headaches are more a problem if somebody's getting the spinal taps, which actually adds to the issue of not wanting to do them unless people really need them.
Gotcha. Okay. I don't see any more questions coming in, so we might just stop there with questions since we're almost at our time. We exit out of that. Before we go, I'd like to highlight how you can connect your records to HealthTree Cure Hub. After creating HealthTree Cure Hub account, you are able to electronically connect your health records from any facility into your profile. Once your records are connected, you can now view a comprehensive overview of your medical history, including diagnosis, genetics, lab results, and treatments, all within a single user-friendly interface. It takes only a few minutes and to create the connection and start taking control of your diagnosis. On the screen, I have a link to sign up for HealthTree Cure Hub, along with the email address to our amazing patient navigators who are able to help you create an account and connect your records. I will also include information about how to enroll in HealthTree Cure Hub on our follow-up email. And then I'd like to just share a couple of upcoming events. So on Tuesday, August 20th, we will have Robin share her story about being one of the first CAR T therapy patients. And on Monday, August 26th, we will have a discussion about treatment options for DLBCL. And the link to sign up for those events is found in the bottom of this slide and will be sent in the follow-up email within 48 hours of the event's completion. As a reminder, we would appreciate you taking the 2 to 3 minute survey, telling us about your experience or if you have any suggestions for future events. And as always, I would like to thank our sponsors for who we would not be able to do this without, and that is Regeneron and Bristol Myers Squibb. And finally, I just want to say thank you for helping us build our DLBCL community. I've added my email to this slide. Please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate you all and hope you have a great rest of your day. I hope to see you at another webinar. Thank you, Dr. Noy. Thank you, everybody, for joining.
Thank you very much.
Of course. Have a great day.
Bye bye.